The digestive system serves as a purpose of breaking down food both mechanically and chemically into components that are small enough for our cells to use. And so once nutrients are broken down sufficiently, they are absorbed from the digestive system into the bloodstream and are transported to the different body tissues. After nutrients from foods are absorbed, some materials remain that cannot be digested or absorbed, like cellulose and fiber, and so these materials are expelled through defecation. The digestive system is broken down into two different categories: the digestive organs, which make up the gastrointestinal or GI tract, or also known as the alimentary canal, and the accessory organs. And so the alimentary canal or GI tract includes the organs of the oral cavity, the pharynx, the esophagus, the stomach, the small intestine, and large intestine. So basically these just form a tube that is continuous from the mouth to the anus. And so the contraction of the muscle in the GI tract wall is able to propel the materials throughout this entire tract. The accessory organs of the digestive system are not part of the long GI tube, but they are connected to the GI tract. So the accessory digestive organs assist the GI tract in the digestion of materials and of different types of foods as well. And so this includes the teeth, the tongue, the salivary glands, the liver, the gallbladder, and the pancreas. The function of the digestive system or the digestive process includes several different steps. We first begin with ingestion, and this is where we introduce solid and liquid materials into our oral cavity and is the first step of processing and digesting and absorbing the nutrients. The next step that we have is digestion, which is the breakdown of large food items into smaller structures and molecules that our body can start to process even more and start to absorb later on. So we have two different stages. We have mechanical digestion, where this is a physical breakdown of materials, and then chemical digestion, which uses different enzymes to break down food. And so mechanical digestion is known as mastication, or the chewing of food in the oral cavity. The next step that we have is the propulsion of food, and this is where materials that are swallowed are moved through the GI tract. And there's two types of movements. We have peristalsis, which is the process of muscular contractions that form ripples along parts of the GI tract and forces material to move further along the tract. So an example of peristalsis is like pushing toothpaste through a toothpaste tube. So as you push on the flat end of one tube, the portion of toothpaste moves toward the opening. And as you push the middle of the tube, the segment of toothpaste moves even closer to the opening. The other type of propulsion that we have is segmentation, where this is the churning and mixing movements in the small intestine, and it helps to disperse the materials being ingested and combine it with the digestive organ secretions. The material within the lumen of the small intestine moves back and forth to help with mixing, and the secretory products are then introduced into that region of the GI tract. And so the contraction and relaxation of the digestive wall helps to create this blender effect due to the smooth muscle. And the next step that we have is secretion, which is the process of producing and releasing mucin or fluids such as acid, bile, and different enzymes of the digestive system. So these help to facilitate chemical digestion and the passage of materials through the GI tract. Some of the products, like the enzymes, the acids, or the bile, help to digest food, where mucin secretes and serves as a protective function, where it mixes with water to form mucus, and then that helps to coat the GI tract and lubricate it so that there are no abrasions that occur throughout the canal. The next step that we have is absorption. And so this involves either the movement or active transport of electrolytes, digestive products, vitamins, and water across the GI tract epithelium and then into the blood and lymph vessels as well. The last step that we have is elimination of waste. And so our bodies use most but not all of the components of what we eat. And so any undigestible materials and waste products, and this includes bacteria, are also then compacted and then are produced into feces. Then feces is eliminated from the GI tract through defecation. So to begin with the GI tract, we'll start with the oral cavity or the mouth, which is the entrance to the GI tract. And this is the initial site of mechanical digestion, which is mastication, and chemical digestion, which is through different enzymes found within the saliva. And so the superior boundary of the oral cavity is formed by the hard and soft palates, and the lateral walls of the oral cavity are formed by the cheeks, which are covered externally by the integument and contain the buccinator muscles. The buccinator muscles compress the cheeks against the teeth to hold some materials in place while chewing. And again, this is why we don't look like chipmunks all the time whenever we have food in our mouth. The cheeks then terminate on the fleshy lips, or the labia, which form the anterior wall of the oral cavity. The lips are formed primarily by the orbicularis oris muscle and are covered with keratinized stratified squamous epithelium. Lips have a reddish color to them because of their abundant supply of superficial blood vessels and reduced amount of keratin within the outer epithelial layer. The palate forms the roof of the oral cavity, and it acts as a barrier to separate it from the nasal cavity. The anterior 2/3 of the palate is the hard palate, and this is where it's hard and bony. And the posterior 1/3 is the soft and muscular portion, which is the soft palate. The hard palate is formed by the palatine process of the maxilla and the horizontal plates of the palatine bones. It is covered with dense connective tissue and non-keratinized stratified squamous epithelium, and it has these friction ridges that assist the tongue in manipulating foods prior to swallowing. The soft palate is primarily composed of skeletal muscle and is covered with non-keratinized stratified squamous epithelium. Extending inferiorly from the posterior part of the soft palate is this conical median projection called the uvula. So when we swallow, the soft palate and the uvula elevate to close off the posterior entrance into the nasopharynx and prevents ingested material from entering the nasal region. The tongue is an accessory digestive organ that is formed primarily from skeletal muscle, and it's covered with stratified squamous epithelium. So there's many papillae that cover the superior or dorsal surface of the tongue, and the tongue also assists in manipulation and mixing of ingested materials during chewing and helps to compress the materials against the palate to turn them into a bolus. The tongue also performs important functions in swallowing. The inferior surface of the tongue attaches to the floor of the oral cavity by a thin vertical mucous membrane called the lingual frenulum. The posterior inferior surface of the tongue contains the lingual tonsils. We have two sets of teeth that develop and erupt during our normal lifetime. The first set is called the deciduous teeth, and this is where we find this in infancy, and where we have 20 teeth. And these are also called milk teeth that are erupt between 6 months to 30 months after birth, and then they're eventually replaced by the 32 permanent teeth that we have as adults. The more anteriorly placed permanent teeth tend to appear first in life, followed by the posteriorly placed teeth. The last teeth to appear are the third molars, or often called the wisdom teeth, that appear in the late teens or early 20s. But oftentimes the jaw lacks the space to accommodate for these final molars, and that may emerge, and they grow at an angle or become impacted, and so usually they're just removed. So the 32 permanent teeth that we have are broken down into different types. And so we have the first are the incisors, and these are the most anteriorly placed, and they're shaped like chisels and have only one root. Their function is for slicing or cutting up food. Immediately posterior and lateral to the incisors are the canine, which have a pointed tip for puncturing and tearing food, especially meats. The premolars are located posterior and laterally to the canines and anterior to the molars, and they have flat crowns with prominent ridges called cusps that are used to crush and grind ingested materials. And premolars have one or two roots. And so these are used a lot for different fruits and vegetables, where we tend to chew a lot of them. Then we have the molars, which are the thickest and most posteriorly placed teeth, and they have large, broad, flat crowns with distinctive cusps and 2 or 3 or more roots. Molars are adapted for grinding and crushing ingested materials. So we think of, in terms of meat, if you use your canines to first break into it, and then you use your molars to chew up that meat. So if the mouth is divided into 4 quadrants, each quadrant would have 2 incisors, 1 canine, 2 premolars, and 3 molars. And so the American dental system, how they number your teeth, is that tooth number 1 is the most posterior tooth on the right side of the maxilla. Numbering continues anteriorly and around the most posterior tooth on the left side of the maxilla, which is then number 16. And then number 17 is going to be the most posterior tooth on the left side of the mandible, and it continues along the mandibular arch to the most posterior tooth on the right side of the mandible, which then is number 32. So if somebody doesn't have their wisdom teeth, the numbering system would start at number 2 instead of number 1. And so here what we have is just a figure of the milk teeth and then versus the permanent teeth, where we'll have the eruption of the primary teeth, and that's what's exposed, and then we have the growth of the primary or the permanent teeth that are formed below that are eventually going to push away the primary teeth. The teeth are collectively known as dentition and are responsible for mastication, which is the first part of mechanical digestion. The tooth has an exposed crown, a constricted neck, and 1 or more roots that anchor it to the jaw. The roots of the teeth are fit tightly into the dental alveoli, which are the sockets that we find within the alveolar processes of both the maxilla and mandible. The enamel is the tough and durable layer that we find that forms the crown of the tooth. Enamel is the hardest substance that we have in our body because it's composed primarily of calcium phosphate crystals. Dentin forms the primary mass of a tooth, and it's comparable to bone but a little bit harder, and it's deep to the enamel. The center of the tooth is the pulp cavity that contains the connective tissue called the pulp. The root of the tooth includes the gingivae, also known as our gums, and these are composed of dense irregular connective tissue that has an overlying keratinized stratified squamous epithelium that covers the alveolar process of the upper and lower jaws and surrounds the neck of the teeth. The root canal opens into the connective tissue through an opening called the apical foramen. And so this is continuous with the pulp cavity, where we find the blood vessels and nerves that pass along through this apical foramen and they're housed in the pulp. And so this is where we have the sensitivity to our teeth. The periodontal ligament is what binds the roots to the alveolar process to form a gum-physis joint. The salivary glands produce and secrete saliva, which is a fluid that assists in the initial activities of digestion. And so daily we have anywhere from 1 to 1.5 liters of saliva that are produced. And most of our saliva is produced during mealtime, but smaller amounts are produced continuously to ensure that our oral cavity is never completely dry, and so that mucous membrane always remains moist. Water is the primary ingredient, which makes up 99.5% of saliva volume. The functions of saliva are to moisten food that we eat and help it to become slick and semi-solid so that a bolus is created and it's easily swallowed. It also helps to moisten, cleanse, and lubricate the oral cavity, and also it is the first step in digestion, where we have amylase in the saliva that breaks down carbohydrates. Saliva also has antibodies and antibacterial substances that help to inhibit bacterial growth in our oral cavity. And also we have a watery medium for food molecules to dissolve into, and so this helps to increase with the stimulation of our taste receptors. We have 3 different kinds of salivary glands that are all connected to the mouth by ducts, where they'll initiate the saliva to, or stimulate the saliva to go enter our oral cavity. The first is the parotid salivary glands, and these are the largest glands, and each parotid gland is located anterior and slightly inferior to the ear and partially overlying the masseter muscle. And they produce about 25 to 30% of our daily saliva. The submandibular salivary glands are inferior to the body of the mandible, and so these produce most of the saliva, which is about 60 to 70%. And the last type is the sublingual salivary glands, which are inferior to the tongue and are internal to the oral cavity mucosa. And so these tiny glands only contribute 3 to 5% of daily saliva production. The pharynx, or throat, is a common space that's used by the respiratory and the digestive systems. It is a funnel-shaped where it has a slightly wider superior region, and then it narrows the more inferiorly you go. It originates posterior to the nasal and oral cavities and extends inferiorly to the level of the bifurcated larynx and esophagus. The regions for the digestive system include the oral pharynx, which is the middle region of the pharynx, and this is immediately posterior to the oral cavity, and it's bounded by the edge of the soft palate superiorly by the hyoid bone and inferiorly by the hyoid bone. It is a common respiratory and digestive pathway for where air and swallowed food and drink pass, and so because of that, it is composed of non-keratinized stratified squamous epithelium. Then the second region is the laryngopharynx, which is the inferior and narrowed region of the pharynx. It extends inferiorly from the hyoid bone and is continuous with the larynx and esophagus. It ends at the superior border of the esophagus, which is equivalent to the inferior border of the cricoid cartilage of the larynx. The esophagus is a tubular passageway for swallowed materials that are being conducted from the pharynx to the stomach. The inferior region of the esophagus connects to the stomach by passing through an opening in the diaphragm called the esophageal hiatus. The esophagus is about 25 centimeters long, or 10 inches long in adults. And at the superior end of the esophagus is the superior esophageal sphincter, or the pharyngeoesophageal sphincter. And this is a thickened ring of circular skeletal muscle that marks the area where the esophagus and the pharynx meets. And this is important because the sphincter is closed during inhalation of air, and so the air doesn't enter the esophagus and enters the larynx and trachea instead. The orifice between the esophagus and the stomach is bound by a thin band of circular smooth muscle, which is the inferior esophageal sphincter, or the cardiac sphincter. The stomach is a muscular J-shaped sac that occupies the left upper quadrant of the abdomen, and it is immediately inferior to the diaphragm. It contains the mechanical and chemical digestion of the bolus, and after the bolus has been completely processed in the stomach, then what's produced is chyme. Chyme has the consistency of a paste-like soup, and the stomach facilitates mechanical digestion by contractions of its thick muscularis layer, initiating this churning and mixing of the bolus and the gastric secretions. The stomach facilitates chemical digestion through gastric secretions of different acids like hydrochloric acid and different enzymes like pepsin. The anatomy of the stomach, we have the cardia, which is the small, narrow, superior entryway into the stomach lumen from the esophagus. And so the cardiac orifice is the internal opening where the cardia meets the esophagus. The fundus is going to be the dome-shaped region, lateral and superior to the esophageal connection with the stomach. Its superior surface contacts the diaphragm. And then the body is the largest region of the stomach, and it's inferior to the cardiac orifice and the fundus. The pylorus is a narrow, medially directed, funnel-shaped pouch that forms the terminal region of the stomach. The opening with the duodenum of the small intestine is called the pyloric orifice, and surrounding the pyloric orifice is a thick ring of circular smooth muscle called the pyloric sphincter. The pyloric sphincter regulates the entrance of chyme into the small intestine by closing upon sympathetic innervation and opening the parasympathetic innervation. The inferior convex border of the stomach is the greater curvature, while the superior concave border is the lesser curvature. The greater omentum attaches to the greater curvature edge of the stomach, and the lesser omentum extends between the lesser curvature and the liver. The gastric folds, or the rugae, are found internally and line the stomach. And these folds are found only when the stomach is empty, and it allows for the great amount of expansion when it fills and then returns to normal J shape when the stomach is emptied. Swallowing is also known as deglutition, which is the process of moving ingested materials from the oral cavity to the stomach. And there are three different phases that occur. The first is the voluntary phase, which occurs after ingestion, and food and saliva mix in the oral cavity. Chewing forms a bolus that is mixed and manipulated by the tongue and then pushes superiorly against the hard palate. The transverse palatine then folds in the hard palate, help to direct the bolus posteriorly towards the oral pharynx. The second phase is the pharyngeal phase, where the bolus reaches the entryway of the oral pharynx, and the tactile sensory receptors trigger this swallowing reflex within the medulla oblongata. The bolus then passes quickly and involuntarily through the pharynx to the esophagus, where we have the soft palate and the uvula elevate to block the passageway between the nasopharynx and oropharynx. The bolus then enters the oropharynx, and the larynx and laryngeal opening elevate toward the epiglottis, ultimately covering and sealing the glottis to prevent swallowing materials from entering into the trachea, which would be terrible because then we have food that enters our lungs. Then the last phase is the esophageal phase, which is involuntary as well, and this is where the bolus passes through the esophagus and into the stomach. This begins when the superior esophageal sphincter relaxes to allow ingested materials into the esophagus. The presence of the bolus with the lumen of the esophagus stimulates peristaltic waves of muscular contraction that assist in propelling the bolus toward the stomach. The soft palate, uvula, and larynx return to the pre-swallowing positions then. Peptic ulcers are solitary erosions of a portion of the lining of either the stomach or the duodenum. Gastric ulcers are peptic ulcers that occur in the stomach, whereas duodenal ulcers are peptic ulcers that occur in the duodenum. Symptoms of an ulcer include a gnawing, burning pain in the gastric region, and can be exacerbated with eating, as well as nausea, vomiting, and extreme belching. Bleeding can also occur, especially within the stool, and so bloody stools are usually a sign of having a peptic ulcer. If the ulcer is left untreated, then it may erode the entire organ wall, and it causes perforation, and then this leads to a medical emergency. Irritation of the gastric mucosa has been linked to many cases of peptic ulcers. So NSAIDs, or nonsteroidal anti-inflammatory drugs like ibuprofen and aspirin, are a common cause of gastritis, and these drugs also impair healing of the gastric lining. Another major cause of peptic ulcers is due to the bacteria Helicobacter pylori, which accounts for 70% of gastric ulcers and 90% of duodenal ulcers. H. pylori resides in the stomach and produces enzymes that breaks down the components in the gastric mucus, and it weakens its protective effects. And so over time, then it destroys the leukocytes as well, and causing the erosion within the gastric lining. The small intestine finishes the chemical digestion process and is responsible for absorbing up to 90% of the nutrients and water. Ingested materials spend at least 12 hours in the small intestine as chemical digestion and absorption are completed. It is 6 feet in the human or living human and about 20 feet in the cadaver, and it's longer in the cadaver because of the muscle tone. The small intestine extends from the pylorus of the stomach to the cecum of the large intestine, and it receives its blood supply from branches of the superior mesenteric artery. The first region is the duodenum, and it forms the initial or first segment of the small intestine, which is about 25 centimeters or 10 inches long, and originates at the pyloric sphincter. The duodenum is arched into a C shape around the head of the pancreas and becomes continuous with the duodenum. The next region then, the duodenum, is the middle region of the small intestine, which is about 2.5 meters and makes up 2/5 of the small intestine's total length. The primary region within the small intestine is for chemical digestion and for nutrient absorption. And the last region, the ileum, is the final region of the small intestine and is about 3.6 meters in length, or 10.8 feet. This forms approximately 3/5 of the small intestine, where its distal end terminates on the ileocecal valve, which is a sphincter that controls the entry of materials into the large intestine. For individuals that undergo stomach stapling or banding, or even with a gastric sleeve, what happens is that part of the stomach is actually banded off and it's redirected straight into the duodenum of the small intestine. And so that there's a smaller pouch of food that is able to be held within the stomach before it continues on to the small intestine, giving individuals a feeling of being full a lot in smaller portions of food. The large intestine forms a three-sided perimeter in the abdominal cavity around the centrally located small intestine. From its origin at the ileocecal junction to its termination at the anus, the large intestine is about 1.5 meters in length, and it's termed the large intestine because it has a greater diameter than that of the large intestine or small intestine. The large intestine absorbs most of the water and ions from the remaining digested materials, and the watery material that first enters the large intestine soon solidifies to become feces, where the large intestine stores the feces until the body is ready to defecate or expel the feces. The large intestine also absorbs a very small percentage of nutrients still remaining in the digested material. The initial segment of the large intestine is a blind sac called the cecum, which is located in the right lower abdominal quadrant. This pouch extends inferiorly from the ileocecal valve, which represents the attachment of the distal end of the small intestine to the proximal region of the large intestine. Projecting inferiorly from the posterior medial region of the cecum is the vermiform appendix, which is a thin, hollow, finger-like sac that's lined by lymphocyte-filled lymphatic nodules. At the level of the ileocecal valve, the colon begins and forms an inverted U-shaped arch. The ascending colon originates at the ileocecal valve and extends superiorly from the superior edge of the cecum along the right lateral border of the abdominal cavity. As it approaches the inferior surface of the liver, the ascending colon makes a 90-degree turn toward the left side of the abdominal cavity. Then it turns into the transverse colon, which curves slightly anteriorly, and it projects horizontally across the anterior region of the abdominal cavity. Then we have the descending colon, which is found along the left side of the abdominal cavity until it terminates at the sigmoid colon. The sigmoid colon originates where the descending colon curves and then inferior immediately turns towards the pelvic cavity. The rectum is connected to the sigmoid colon and is a muscular tube that readily expands to store accumulated fecal material prior to defecation. There are 3 thick transverse folds of the rectum called the rectal valves that ensure that the fecal matter is retained during the passing of gas. The rectum then terminates at the anal canal. The anal canal passes through an opening, and the internal lining of the anal canal contains relatively thin longitudinal ridges called anal columns, where between them are small depressions called the anal sinuses. As fecal material passes through the anal canal during defecation, pressure exerted on the anal sinuses causes their cells to release excess mucin, which lubricates the anal canal during defecation. There are two sphincters, an internal and an external anal sphincter, which close off the opening of the anal canal and relax during defecation. The internal anal sphincter is involuntary, whereas the external anal sphincter is voluntary. After food is swallowed, it moves through the GI tract by a process called propulsion. And so there are two types of movement involved. We have peristalsis and segmentation. Peristalsis is the process of muscular contractions that form ripples along parts of the GI tract and forces materials to move further along the tract. So it's like pushing toothpaste through a toothpaste tube. As you push on the flat end of the tube, a portion of toothpaste moves toward the opening, and as you push the middle of the tube, the segment of toothpaste moves even closer to the opening. The second type is segmentation, which is churning and mixing movements that occurs within the small intestine. And so this helps to disperse the material being digested and combine it with the digestive organ secretions. The material within the lumen of the small intestine is moved back and forth to mix it with the secretory products that are being introduced into that region of the GI tract. When contraction and relaxation of the digestive wall musculature creates this blender effect where it mixes ingested materials with digestive enzymes and mechanically breaking down larger digestive particles into smaller ones, as well as the chemical digestion with the enzymes. The liver lies in the upper quadrant of the abdomen, and it is immediately inferior to the diaphragm. It weighs about 2.25 or 4.5 pounds, and so this makes up about 2% of our body weight. The function of the liver is to produce bile, and within the liver cells, the hepatocytes, they also detoxify drugs, metabolites, and different poisons that we come in contact to, including alcohol. The liver cells, the hepatocytes, also store extra nutrients and vitamins that are released when they are needed. And they also synthesize blood plasma proteins such as the albumins, globulins, and the proteins needed for blood clotting. The liver is made into 4 incompletely separated lobes and is supported by 2 different ligaments. The major lobes that we have are the right and the left lobe, where the right lobe is larger than the left lobe, and the right lobe is separated from the left lobe by the falciform ligament, which secures the liver to the abdominal wall on the anterior side. We also have the subdivisions of the right lobe into 2 separate lobes, which are the caudate lobe and the quadrate lobe, where the caudate lobe is adjacent to the inferior vena cava and the quadrate lobe is adjacent to the gallbladder. We also have the hepatic portal veins that carry blood from the capillary beds of the GI tract, the spleen, and the pancreas found within the liver. This is where blood volume is about 75% that enters into the hepatic portal vein, and this is rich in nutrients and other absorbed substances that is relatively poor in oxygen. The arteries are part of the celiac trunk and carry well-oxygenated blood to the liver. The hepatic veins then eventually empty into the inferior vena cava. The cells of the liver, the hepatocytes, also produce bile, which is a greenish fluid that breaks down fats to assist in chemical digestion. Chronic injury to the liver can cause liver cirrhosis, and cirrhosis means a yellowing, and so that's why a lot of people who have cirrhosis of the liver tend to have a yellow-colored liver. This is when the hepatocytes, the cells of the liver, are destroyed and are replaced by fibrous scar tissue, and can result from chronic alcoholism, liver disease, or different drugs and toxins that one is exposed to throughout their lives. So what happens is that this excessive scar tissue compresses the blood vessels and the bile duct in the liver, and this causes hypertension, which is high blood pressure in the hepatic portal venous system, and so bile flow is impeded from that. The gallbladder is found on the inferior surface of the liver, and it is a sac-like organ that concentrates bile, which is produced by the liver and stores the concentrate until it's ready for digestion. The cystic duct connects the gallbladder to the common bile duct, where we have the dumping of the bile into the duodenum of the small intestine. The pancreas is both an endocrine and exocrine gland because the endocrine functions are performed by the cells of the pancreatic islets, and the exocrine activity results in the secretion of digestive enzymes and bicarbonate, which is pancreatic juice that is secreted into the duodenum of the small intestine. Most of the pancreatic juice travels through the ducts that merge into the main pancreatic duct, and where we have the hepatopancreatic ampullae, this is found on the posterior side, and it is a swelling in the duodenal wall where the common bile duct and the main pancreatic duct merge and pierce into the duodenal wall, and so we have bile and pancreatic juices that mix together into the duodenum to help break down fats. The abdominal pelvic cavity is lined with a moist serous membrane that lines the inside surface of the body wall called the peritoneum. The portion of the serous membrane that folds back or reflects to cover the surface of the internal organs is the visceral peritoneum. In between these two layers is the peritoneal cavity, which is a potential space where the peritoneal layers that face each other secrete a lubricating serous fluid. The thin layer of fluid in the peritoneal cavity lubricates both the body wall and the internal organ surfaces, allowing the abdominal organs to move freely and reducing any friction from movement with digestion. So the organs that are completely surrounded by visceral peritoneum are the interperitoneal organs, and they include the stomach, part of the duodenum of the small intestine, the duodenum and the ileum of the small intestine, the cecum, appendix, the transverse and sigmoidal colon of the large intestine. The retroperitoneal organs typically lie directly against the posterior abdominal wall, so only the anterolateral portions are covered with the peritoneum. And so these organs include most of the duodenum, the pancreas, the ascending and descending colon of the large intestines, and the rectum. A condition of a faulty peritoneal cavity occurs or is called peritonitis. And so this is where we have inflammation and infection of the peritoneum due to leakage of contents into the peritoneal cavity. This could be caused by a variety of reasons, such as a bacterial infection, a rupturing of the organ, or due to complications with surgery. And this can be fatal, so if the appendix, say, bursts and it enters into the peritoneal cavity, then this would cause inflammation that could be fatal. And a lot of times, diagnosis of this is when individuals undergo surgery, they tend to have this thickening and yellowing covering of the peritoneal surface, indicating a bacterial infection that has occurred.